So now we are ready for our second to last speaker. This great symposium day is coming soon to a close, but not before. This is the dessert. We're entering the dessert section of this symposium. And we're really lucky to have had amazing nephrologists join our team this year. Dr. Roche-Recinos has already made a great impression on our team and on me. Feel very lucky that we have her, and she has gracefully accepted after we pleaded with her for a while, mainly Dr. Markil pleaded with her, to come and discuss kidney allocation system, its role in access to transplant in underserved community. Dr. Roche-Recinos.
All right, so I will talk a little bit about the kidney allocation and the efforts to increase access to transplant. By the year 2000, the federal government issued the Organ Procurement and Transplantation Network final rule that is supposed to guide the allocation policy by basing it on sound medical knowledge, seeking to achieve the best use of donated organs and designed to avoid waste and futile transplants and to promote the patient for access to transplantation. By 2004, kidneys were offered based on waiting time. This meant that the system was heavily weighted on allowing equal access to transplant, but there were no efforts made into improve the best use of kidneys. So very, young recipients would receive a high KDPI kidney and vice versa. So it became evident that a balance was needed to find the best use of kidneys and allow equal access to organs for all the waitlisted patients. It also became evident to the transplant community that some racial, ethnic groups have, along each step of the kidney transplant process, a harder time to get refer, complete the evaluation, listed, and eventually get transplanted. This happens to Black patients, Hispanic patients, and it's also based as well on your socioeconomic status. How can you can get there? Not only in the pre-transplant evaluation part, but also as in the transplant outcomes. As you can see, Black patients have lower rates of graft survival 1, 3, 5 years after, and it has been attributed to various factors as risk factors for this outcome: sociocultural, socioeconomic, geographic factors that can affect this. Even before the patient gets in touch with the transplant infrastructure, the existing socioeconomic deprivation has a lot to do with the patient's ability to reach the medical system and be referred and listed. If you see, this figure tries to show the many determinants of CKD, obesity, diabetes, hypertension, endothelial dysfunction, oxidative stress, neurohormonal activation, that may have their foundation and their basis on their socioeconomic disparity. And these will eventually all come together to influence the CKD and its progression, which will end up in end-stage renal disease and premature mortality. There are many barriers along the way, like I was mentioning: patient barrier, provider barrier, transplant center, barrier to preemptive wait listing, and also just to eventually reach the transplantation process. Not receiving an education regarding kidney transplant is associated with a 53% lower rate of any access to transplantation and 65% lower rate of living donor kidney transplant as well. We are going to talk, I will talk a little bit later about the race coefficient in the equation when trying to estimate the kidney function of our patients and how this limited the access. As far as the provider level, it's important to note many times dialysis patients say that they are not seeking transplantation, that they're not interested in transplantation because either their PCP or even their nephrologist has told them that they're not candidates, when the right way should be to refer the patient and after careful evaluation, have the transplant center make that decision after carefully reviewing all their pre-transplant workup. So because of this, there has been a lot of efforts to try to achieve racial equity in transplantation. In 1992, there was a creation of the Minority Affairs Committee that was tried to uphold the equitable organ allocation across racial ethnic groups and vulnerable populations. In 2002, there was a variance to improve equity among blood types. And this is important because it is well known that some blood groups, because of their less frequency, are also spending longer time in the wait list. And the wait list time as well is also historically used to be dependent on the time of referral and eventual listing in the wait list. By 2014, the kidney allocation system allowed patients to accrue waiting time even if they were referred and evaluated and eventually listed after they had started dialysis by tracking their time. So in 2014, the new kidney allocation system was in place to increase the utilization of available kidneys, reduce the regional variability, try to do some more longevity matching between the donor's age, the recipient age, by the measure of the estimated post-transplant survival as well as the KDPI. And certain groups were going to have additional priority, less common blood types such as type B, and increased calculated panel-reactive antibodies. Highly sensitized patients were going to have a higher priority points, and the change in the waiting time. However, this study here looked at the period after implementation of the kidney allocation system. After 2014, the authors looked at the patients, incident dialysis patients between 2015 and 2019, and above 400,000 patients, adults, were looked at, and there was a significant disparity in kidney transplant wait list. In non-Hispanic Black patients were, in total, 14% less likely to be listed, and when they looked at the age group between the ages of 18 to 29, 27% of these patients were less likely to be listed. So still, even after these changes, patients were having not the desired effect of having the access to the wait list. And then the final most recent revision of the kidney allocation system was done in 2021. The kidney allocation system 250, which allows the use of a 250 nautical mile circle center on the donor's location. And this is precisely to try to reduce the geographic disparities, as if you remember the morning session, it was mentioned by Dr. Rochon, patients in Florida get transplanted really fast, and this is the geographic disparity that this revision tried to diminish. As mentioned before as well, historically, there was a Black race coefficient added to the estimation of the kidney function. So you could have two patients looking the same in terms of sex, age, and serum creatinine, but one would be identified or categorized as Black and the other as non-Black. And you can see the difference. Candidate B, who is not Black, was ready to start accruing time, whereas candidate A was not. And the initial idea that there had to be a coefficient was based on studies in the 90s that show that black patients were higher producers of creatine, and for this reason they had higher levels of serum creatine. But definitely this disadvantage their timely referral to nephrology and then to a transplant center. And it was ended up not being based on anything medical or genetic, just social, which is the attribution of race. So even if you use different equations, for example, the MDRD equation or the CKD-EPI equation, you can see the change in the overestimation of the patient's kidney function, and how this will alter the way we provide medications. Again, their starting of dialysis, the referral to transplant. So recent studies again demonstrated that for non-black candidates were listed preemptively nearly twice as frequent as black candidates in 2019 and at a higher eGFR levels. So by July 2022, it was hospitals were required to use eGFR formulas without the race coefficient. And then it became a policy that was instituted in January 5th, 2023 to allow black recipient candidates to receive the waiting time if a race-neutral eGFR calculation would have been used at the time of their assessment. So all transplant centers were requested to assess their wait list, notify all candidates, and submit the time modifications. This was done in Downstate as well. And 309 patients were reviewed as of May 13 of this year, 260 identified as black, but only 17 patients were approved for the wait time adjustment. And this is, as mentioned before, many of these patients were not able to bring us any evidence that they were seen and evaluated before and that their eGFR was lower. So despite the efforts, racial disparities still exist, despite the creation of policies designed to try to decrease these. And they exist even before the patient is in contact with the transplant center. So a few things that can be changed is increase the staff and patient education and awareness, continue to work on early referrals, increase advocacy, increase access. Those are the things that could potentially make a difference in how patients have access and are eventually waitlisted and transplanted. Thank you. Any questions?